Now I'm going to switch gears. That was a run-through of 12 lessons. I'm going to spend more time on the question of equitable global distribution of vaccines. After COVID began, but we still didn't have a vaccine. So over the summer of 2020, the fall of 2020, there was a lot of global discussion about fair and equitable vaccine distribution when we got a vaccine. There was much worry at the WHO, much worry among NGOs, and even leaders of countries that the distribution would be unfair. There was an editorial, I think it was in the Washington Post in the United States, by the Prime Minister of New Zealand, the Prime Minister of Canada, and others, 5 world leaders, that we should not let the vaccine distribution be unfair and inequitable. This was a legitimate worry, right? If we left the vaccine distribution to the market does what the market does, and what does a market do? The goods go to the person who's willing to pay the most, rich people, rich countries. And so they was worried that high-income countries would buy up available vaccine and leave lower middle-income countries with few, if any, vaccines. So, what happened? Was the global distribution of vaccines unfair and inequitable? I'm not going to put anyone on the spot by asking for a show of hands how many people think it was unfair, who was it unfair to. So the question is, how do we assess whether it was fair or not fair? How do we determine that? So it's a 3-step approach. You need to think about this logically. Step 1, what's the right ethical standard for fairness and equity in the global distribution of vaccine? Step 2, based on that standard, what is your equity metric? What's the right number you're looking for? How do you assess it quantitatively? And step 3, what's the data show? Okay, once you've got the metric, what does actually the data show on that metric? So we'll go through these 3 steps. The problem is, there are 2 different arguments for what is equitable and fair in the global distribution of any good among countries. One was articulated by the WHO in COVAX, and that was a population-based standard. Their standard said we're going to give vaccines to countries based upon population, and therefore the equity metric is vaccines per person in a country. I was part of a group that I put together called, and we called our model the fair priority model. And we argued that it's not population, but it's COVID health burden. It's how many people are dying. And therefore, the equity metric is not vaccine per person, but vaccine per excess deaths in a country. This come out, there are obviously 2 very different standards. Maybe they come out the same, maybe they don't. It depends upon the data. So let's go through these. COVAX, all countries should receive the same number of vaccines. And their main thing is they would distribute vaccines to 3% initially, equally among all countries, 3% of the population, to cover healthcare workers and other essential workers. Then they would go up to 20% of the population, again, distributing it evenly around the world, kind of, I guess you don't have the same. We have a phrase called distributed like peanut butter, that goes smoothly. I don't know what the equivalent in Taiwan is, but where it's smooth across all the globe. That was their view, up to 20%. Our view was different. You have to look at the COVID health need. We argued that vaccines should be allocated to the country based on where they will relieve the most COVID health burden. Where are they going to impact COVID the most? Now, health burden should include excess deaths, both directly caused by COVID deaths, and indirect deaths. That's deaths caused by a healthcare system that's overwhelmed. Deaths caused by people not willing to go to the hospital because they don't want to get COVID. So they might, unfortunately, have a heart attack but not go. Or they might have some other problem, not get their cancer chemotherapy. So you need to assess both. Oops. Now, this leads to two separate equity metrics. On the population-based standard, it implies that the appropriate equity metric is the number of vaccines per country. And that was what COVAX did. It distributed the vaccines it got by population of the countries that signed up. Our health needs-based standard emphasizes excess deaths. And that is, the equity metric is vaccines should go to the countries with the most excess deaths in order to save the most lives. Two very different standards. The question is, what does the data show? Well, the empirical evaluation of the population-based metric. This is a graphic that appeared in the New England Journal of Medicine, written by the editors, but reflects common view, is the vaccine allocation was grossly inequitable. And you can see that low-income countries got very few vaccines per population, and high-income and upper-middle-income countries a lot, lower-middle-income in between. So that by the end of 2021, and by the end of 2021, vaccine was freely available. Everyone could buy as much as they want. The world was awash in vaccine. The problem was there was no demand. Rich countries had 7 times more vaccines than low-income countries, and 2 times more than lower middle-income countries. And on this assessment, there were many declarations by the WHO, by UN, that the distribution was morally wrong, that the world failed in its requirement. There's actually a quote from this Director General, or the Secretary General of the UN, that the world failed on the vaccine distribution. The empirical evaluation of the health needs standard is much more complicated and more nuanced. The evaluation must look at excess deaths per country at the time you had to make a vaccine allocation. So, if the vaccine was approved or authorized, wasn't approved, was authorized in December 2020, you have to look at what is the excess deaths in December 2020 to decide how you distribute your vaccine and which countries should be at the top of the priority list. Well, what is it? What do we know about that? First thing I will tell you is the excess deaths do not closely link to countries' income. It's not that you're poor, you have more excess deaths, you're rich, you have fewer excess deaths, or you're rich, you have more excess deaths, you're poor, you have none. Excess deaths in the country is determined by things like surges in the virus, the demographic age distribution, population-based health, like you have a lot of comorbidities, obesity or diabetes that we know make people prone to dying, adherence to public health measures, and other items. So just take, for example, among high-income countries, excess deaths in 2020. So if you accumulate all deaths between March and December 2020, the United States had the most excess deaths at 465,000. Japan had actually fewer deaths than normal. People stayed home, people stopped driving, you had fewer deaths, it turned out. Taiwan too. So, negative excess deaths. This was upper income countries. You go to lower income countries and the same distribution happens. Zambia had, 5,000 excess deaths. Rwanda, negative. So you just can't say, look at income strata. That makes no sense on this metric. If you look at the top countries, okay, this is the top countries as of December 2020, cumulatively. The United States was the number one. We had almost 1 in 7 deaths worldwide were in the United States. Indonesia was number 2 with 10%. Mexico number 3, and then it fell off. Okay? And you can see 2 high-income countries in the top 10. The others are middle-income countries. No low-income country in the top 10. The top 10 ended up with 60% of all debt. Just 10 countries had 60% of all excess debts. 10 countries. And the rest of the world had 40%. Now, you don't have to be a genius to say, well, maybe those top 10 or top 15 or something ought to get most of the vaccine. That's where the deaths are happening. So, again, as I said, the top 10, 2 are high income, 4 are upper middle income, 4 are lower. There's no low income or sub-Saharan country there. The low income country with the highest excess deaths, Congo at 24. Not even in the top 20. In June 2021, which is the first time we actually have accurate data on vaccine distribution in the world, data from all the countries. So we look at deaths in 2020 and then vaccines in 2021. We find out that in June 2020 we had a similar finding that actually, hold on. These 10 countries are all the same except Italy now drops out and South Africa goes in. So you've got 1 sub-Saharan Africa in the top 10 now. But other than that, all these countries are basically the same. They shift places a little bit, but they're roughly the same. So, as I said, vaccines in 2021. At that point, countries with the worst deaths did not necessarily receive the most vaccines. In fact, countries not receiving vaccines despite high excess deaths were largely middle-income countries. So Peru had only 68 vaccines per excess death, Mexico 173, Turkey 423. And this is a complicated chart, but let me walk you through. So here's the top countries in terms of deaths. And here are some others that will be interested. The United Kingdom that made the AstraZeneca vaccine, South Africa, Colombia, Somalia, Mali, just taking some poor countries. Lithuania, Ghana, which was the first country to get vaccines from COVAX in February of 2021, Mozambique, Zambia, Rwanda. Now, you can see the excess deaths. This is in descending order. 4 countries, right? Not very many excess deaths. Vaccines per excess deaths. Yes, they had few. Although Ghana had a lot, but Egypt had fewer. And places like Mozambique, high number at 130 over a place like Egypt. If you look at their ranking, so this is the most excess deaths, the second most, third most, fourth most, fifth most. You can see that in terms of vaccines per excess deaths, they go way down. Sorry, I keep doing this. You can see here that some countries, like Ghana, 129, not that bad. Rwanda, 10, because it had negative excess deaths. So there's no simple income strata relationship. Countries with the most cumulative deaths compared to all other countries. By December 2021, the situation, as I said, was largely similar, except South Africa replaced Italy and Egypt moved up. Okay. I think you can draw 4 conclusions when you look at all these data, and I'm happy to provide you with the charts that I developed. First, select middle-income countries like Peru, like Brazil, like Mexico, like Indonesia, were treated most inequitably, those with high excess deaths and too few vaccines. They went from number 1, Indonesia, with excess deaths, to 120 in terms of vaccines per excess death. Countries with negative excess deaths and low total excess deaths, that is, they had fewer than 15,000 excess deaths, they received too many vaccines. And then again, that's not uniform. The worst offender, probably seen it. Vaccine-producing countries, the US and UK, did not receive too many vaccines per death because they were very high up in terms of number of deaths, excess deaths. They actually had, US was number 1 initially. Low-income and sub-Saharan countries, except South Africa, were generally not treated inequitably because they had hardly any excess deaths. You have countries that have, I mean, at the end, Ghana had 6,400 excess deaths. In terms of the world, it was nowhere, 120th. So here's some middle-income countries were treated most inequitably, and here you see Indonesia in terms of excess deaths, and then vaccines for excess death. You can see Indonesia was number 1 in terms of excess deaths, moved down to 123 in terms of vaccines for excess deaths. Mexico was number 3, moved to 136. Peru was number 4, moved to 154 in terms of vaccines for excess death. And you can see the high countries went far down. But a place like Ghana, as I mentioned, 6,400 excess deaths, but not very high excess deaths, and vaccines for excess deaths over 200. In December 2020, there were 39 countries, including 2 low-income countries, 11 lower middle, 13 upper middle, and 39 income countries that had negative excess deaths, like Japan, like Taiwan, I guess. And there were 101 countries with less than 15,000 excess deaths. Small number. When a vaccine is in extremely short supply, as it was in December 2020, because we had just been able to produce it, these countries should not have gotten vaccine. Inequitable for them to get vaccine. Countries that manufactured, the US and UK, were often condemned for taking too much, even though they developed it. But the data suggests maybe they were not receiving too many. They had high numbers of excess deaths. And they had vaccine, but the US was number 1 in December 2020, but we were 84th in terms of vaccines for excess death by June. Hardly at the top to be condemned. And then, as I mentioned, low-income and sub-Saharan countries, except South Africa, were largely not treated inequitably. They did receive few vaccines, but they also had very few excess deaths. Why would you pour in a lot of vaccines when there aren't excess deaths happening? Okay. So we have these 2 standards. One says low-income countries were treated very badly. The other says low-income countries weren't treated badly. One says middle-income countries were not treated badly. The other says middle-income countries were treated badly. One says you can look at income strata, and that makes a lot of sense. The other says, don't look at income strata, you need to look at excess deaths in a population. Which standard is the right standard? Well, COVAX never once defended its standard as an ethical standard. They could never articulate why was it the right standard, the right standard. Why was it the standard for fairness? The justification COVAX gave is it was politically smarter to do it by population. They said a proportional population-based allocation should provide certainty to all countries abiding by the global allocation framework that they will receive a sizable number of vaccine doses and will encourage a large number of countries to participate in a common mechanism and process. So the justification is we want countries to participate. If you want countries to participate, you need to give them an incentive. And the incentive is you'll get vaccine according to your population, no matter what the health burden is in your country. That is not an ethical justification, it's a political justification. On the other hand, the health needs standard that we articulated is an ethical principle. We articulated it based upon 3 fundamental ethical values. We should minimize harm, minimize deaths, because that's the greatest harm. We should mitigate disparities, and we should provide equal moral concern. The way you provide equal moral concern does not give every country the same. If someone's suffering, you give them more. We know this, right? You don't look at HIV and say, okay, we're going to take antiretrovirals, we're going to spread them evenly across the globe, right? What do we do in PEPFAR? Where are the countries suffering the most? Let's give them to those poor in sub-Saharan African countries, give them antiretrovirals. Prioritizing allocation to countries where it can maximally reduce deaths is justified by, obviously, maximizing benefits and minimizing harms. Because you want to minimize the worst of all harms, which is death. Prioritizing allocation to countries with the highest COVID deaths fulfills equal moral concern. It recognizes a fair distribution of COVID-19 vaccines should respond to the pandemic's differential severity in different countries. Equal moral concern does not mean equality. Everyone gets exactly the same amount. It means you give the amount relative to the need of those people. Now, the COVID health needs standard, it turns out, while it was not initially developed by the WHO has embraced it today. If you look at the draft pandemic treaty that has been circulated, Article 6, Paragraph 3 of the draft indicates pandemic vaccines and other countermeasures should be allocated fairly and equitably, quote, based on public health risks and needs. Doesn't say based upon population. Gave up that standard. The Pan American Healthcare Organization also accepts the health burden standard. When they were distributing Mpox vaccines, they said the Pan American Sanitary Bureau considers that extraordinary negotiations are needed to ensure that the region of Americas has equitable access to this smallpox and Mpox vaccine through the revolving fund. An equitable allocation entails prioritizing health needs which will maximize the impact of vaccines. It doesn't say anything about distributing them uniformly across Latin America and the Caribbean. And in fact, if you look at the way the WHO is going to distribute the malaria vaccine that it recently approved, it's going to countries with high malaria rates, not moderate or low, because that's where the health need is. So they seem to have now embraced the health need standard, not the population need standard. Okay, so what can we conclude? The claim that low-income and sub-Saharan countries were not treated unfairly or equitably in the distribution of COVID vaccines, and that mainly a few middle-income countries with high excess deaths were treated unfairly, is not the popular view. In this case, while low-income and sub-Saharan countries receive few vaccines, they also have very few excess deaths. And therefore, it's hard to say that they were treated unfairly or inequitably. The real inequity is that those countries suffering the most, Peru, Indonesia, did not receive enough vaccines. All right, we can go through these, but I think it's better in the interest of time to get to a rapid discussion. Okay, thank you.